Hello. Have you been thinking about COVID, monkeypox, vaccinations? What will the winter weather bring? Stay tuned and learn more. I am so honored to have with us the Linda Vail, Health Officer, Ingham County Health Department, but so much more than that. Hi, Linda. How are you?
I'm great, Paula, and I am so happy and honored to be here with you. You are a rock star.
Well, let's look who's talking. I mean, you have been the last 2.5 years have probably been the most challenging of any health officer anywhere in the country. But for you, well, work that you've done navigating us through COVID and through all the changes that have taken place has been quite a challenging year, a couple of years, correct?
It has been really, it's been quite a challenge. It's challenging and rewarding at the same time. When you love the work you do, unfortunately, you can just bury yourself in it. And there were 18-hour days and 7 days a week and month after month after month of work. And you just pour yourself into it. And everybody kept saying, you need to take care of yourself. And then you kind of get the other end of it. It's like, I think I should have taken care of myself.
Well, you certainly were busy taking care of so many millions of other people as well. But tell us a little bit about your background. I mean, we know you're the health officer. We know that you're in charge of Ingham County Health Department. But what's the journey that led you to that position?
Oh, my goodness. So I went to the University of Georgia, grew up in Georgia. My background is in infectious diseases. My degree is microbiology. And from there, I went into biomedical research. I worked at the University of Georgia for a couple of years. I worked at Vanderbilt University Medical Center in their biochemistry department for a couple of years. And I ended up in Michigan, in Kalamazoo, to work for what was the Upjohn Company and is now Pfizer. And so I spent 20 years doing biomedical research. When I ended up in corporate pharmaceutical biomedical research, I did everything from cancer research to central nervous systems research, cardiovascular research. They're product oriented, so when they decide to go a different way, you just do a different kind of research, which is different than academics. So I did that until 2002. I have a master's in public administration with a public health concentration from Western Michigan University, which I did while I was working with the Upjohn Company. And when Pfizer acquired what was then Pharmacia, I actually lost my job. I was laid off. So in July of 2002, I was unemployed, living off unemployment and child support and trying to figure out how I was going to keep my kids in my house. And by November of 2002, I was an entry-level coordinator at the Kalamazoo County Health Department, doing emergency preparedness and pandemic, response planning and stuff like that.
With all those degrees and all that experience and background, you didn't have a job.
Well, you get laid off.
Yeah.
That's what happened.
Yeah.
But it only lasted for 3 months. I applied. I got that job and had never worked in public health in my life. In November of 2002, set in the first health department that I'd ever worked in. And 4.5 years later, I was their health officer.
And here you are today. Here you are today in 2022 and leading a county and also a national figure in terms of how you've led this county, Ingham County in particular, through this COVID epidemic. Where are we now with COVID? What's the status right now?
Right now with COVID, our numbers here really are actually going down. I've been watching for I looked yesterday, it's like, wow, we're actually back down to low. A few weeks ago, we were at, CDC's high level. So I would expect we're going to have, a fall winter surge at some point in time, but it will be at some point in time a normal pattern. And what we're looking for is for COVID to turn into a normal, predictable pattern, and then it won't be a pandemic anymore. As long as it's this unpredictable, waves and peaks, all kinds of different times of the year that we can't predict and don't know what's coming next, then we're kind of still in pandemic mode. But we expect to fall into a seasonal, like a flu pattern, that's fairly predictable with COVID, as immunity is, kind of spreading either from having gotten COVID or being immunized or both. And then that predictable pattern, which, maybe this year is going to be it. We'll see COVID numbers go up, sort of like flu numbers. We'll have a peak sometime in the winter, they'll go back down, and maybe we'll be in something a little bit more predictable by next year.
Will you be recommending that people continue to wear masks indefinitely?
There is no harm in wearing masks. As you can hear my voice right now, I have a little something. And I think a lot of people discovered during, the season that we tend to get these various respiratory illnesses when we were required to wear masks because of COVID, that a lot of us didn't get these things. My daughter ran a half marathon this last weekend, and she's planning on running a marathon out in California. There's a lot of preparation that goes into that. And she was feeling a little sick before the half marathon. She says, you know what? Before I go to that marathon in California, I'm going to wear a mask that whole month before. I was like, well, and she says, colds, this, that, whatever. I don't want to risk that. So, there are obviously some benefits to that. And people are going to make their choices at this point in time. I would not expect to see any mask orders or requirements or anything like that moving forward.
But particularly indoors, large crowds, airplanes, whatever, that you might just want to take that extra precaution.
Yeah, and especially at this point in time, it really is an evaluation too of yourself and the context of your life. Like, are you older? Are you, do you have diabetes and high blood pressure, overweight, those sorts of things? Those put you more at risk. Right. Are you living with somebody or do you interact regularly with somebody who's severely immunocompromised, so that if you bring something back to them, that becomes a problem for them? Those are all factors to take into account for your own self. So people need to be making those individual decisions really based on their own risk factors as well, which of course go down significantly if you stay up to date with your vaccine.
Yeah, absolutely. And we're going to talk about vaccines and monkeypox in just a moment. But there's been this misperception that once you've had COVID, you're immune for 3 months, 6 months, or whatever. And then the President of the United States got COVID twice within a very short period of time. When you talk about the pattern or the flow, tell us, are you ever immune from it if you've had it? Is there an immune period?
There probably is an immune period, but it probably varies as these variants have come along. So same thing happened to me. I had COVID twice in 4 months. I had COVID in October and I had COVID in February. So not quite as short a period of time, but that was back when we had Delta first. So I had Delta in October and then Omicron. So Omicron's a little bit more transmissible. It would make sense that maybe, the immunity wouldn't hold out. And again, we're talking about a president that's an older man. Right. And so his immune system is not going to stay as strong for as long just because of his age.
And so the vaccine that's out now, will it take care of all these different variants? If you take that now, what's it called? The new vaccine?
It's a bivalent.
A bivalent, yeah. So if you get that, it's supposed to help with a lot of the variants, correct?
Right. What bivalent means is that it covers 2 different things. So there are proteins in that vaccine that are the spike protein it's the mRNA actually, but there's something to basically create immunity to the original spike protein of the original virus, as well as the BA4, BA5 variant. And so you're getting coverage kind of across multiple strains, or at least 2 different strains. Flu is the same thing. It's a quadrivalent vaccine. It covers 2 influenza A strains and it covers 2 influenza B strains. So you're getting a quadrivalent or a 4 different types of, flu strain vaccine when you get a flu vaccine. So it's a very common thing when we see these different viruses that have this tendency to create variants.
Linda, does each variant get weaker or do they get stronger?
They,
or both.
Evolutionarily speaking, when you think about it, it would tend to get weaker, which is what we're seeing. Viruses, bacteria can grow, in like your refrigerator on things all by themselves. Bacteria can grow on Petri plates and things like that. A virus can't grow anywhere except inside a host cell. It requires the cells of your body to grow in. And if it becomes too severe and kills too many of its hosts, it essentially kills itself out. So as it becomes less virulent, it's actually creating a more survivable virus itself. So that is kind of a typical pattern that you would expect to see it to become less severe.
So for people who have not yet gotten a vaccination, and I know there's some that have religious reasons, and so, I understand that, but what would you give some encouragement to folks who are still a little bit hesitant? I mean, I heard someone say once that more people are dying from not getting the vaccine than getting the vaccine.
Oh, of course.
And so if you want to balance your risk, then get the vaccine and you live longer. But inspire folks to get the vaccine if they haven't, or why they should even get the booster.
Well, I mean, why should you get the vaccine? The data is very, very, very clear. As we look at the data now between vaccinated people and unvaccinated people, one thing we do know that we were hoping would not be the case is that, people are getting infected whether they're vaccinated or not. But as more people are vaccinated, the pool of people that can get infected are mostly vaccinated, so that makes sense to some extent as well. But what we don't see with people who are up to date with their vaccine is severe illness, hospitalizations, and deaths. So that's kind of important.
Yeah, right. Absolutely.
Getting a little case of COVID, and honestly, my last case of COVID was about as severe as what I've got right now. It was a little bit of laryngitis and some congestion, and I worked at home to keep anybody from getting it from me. But other than that, it was very, very mild. On the other hand, people who are unvaccinated are still dying. They're still ending up in the hospital with very severe cases of COVID. And the other thing too is we're 2.5 years into knowing about this virus. We're learning, you are watching science unravel in front of you.
Right.
Again, I spent 20 years in a biomedical research career doing science, and this has been science live. So you've been watching us do science. We're learning as we go. So what we don't know that much about at this point is long COVID. We know people get long COVID. I know people who have long COVID still. I have a friend that late in her life went to Chicago and got a degree in photography and was starting her career, and two things have happened to her. She has post-concussion syndrome and she has long COVID, and she is currently unable to even, use her camera and things like that. So she's, 58 years old and was going to start a late in life brand new career, and that's kind of been taken out from under her because of her cognitive abilities.
So people need to get that vaccine. Mm-hmm. They need to get the vaccine.
Yeah, and even young children. I was talking to my daughter this weekend. My youngest granddaughter is 4, and so she just became eligible for a vaccine. It's like, I can agree with you that they don't tend to get that sick. She's probably had COVID and was asymptomatic because she's the only one in the family that technically hasn't had COVID yet. But even in youngsters, what about long COVID? And when you know that the virus can affect your your sense of taste and smell, and this long COVID with brain fog and stuff like that, you've got some neurological impact. And these are young, developing brains. And so I think you want to be cautious about that.
Absolutely. So, COVID and the flu shot, should they get?
Absolutely.
Yeah.
Yeah, and there's no reason you can't get them both at the same time.
Mm-hmm. Now there's something called monkeypox.
Yeah.
like we didn't have enough. Yeah, so right. COVID wasn't enough. So talk about monkeypox and what we need to know about monkeypox.
Monkeypox is not a highly transmissible virus. It requires very close contact, exchange of saliva, that sort of thing. Touching, the sores, the monkeypox sores that might be there. So, you're not going to have an airborne or be at high risk. We've had 5 cases of monkeypox in Ingham County, and that's where we have stood for quite a while. So it's very easy to basically be aware of what monkeypox is, how it's transmitted, what that looks like, and to protect yourself from that. And so I think one of the reasons we aren't seeing more cases is when a virus is so much less transmissible like that, it's a lot easier to contain. You saw us doing all this isolation and quarantine. Those are public health tools to contain the spread of a virus. When something's very, very highly transmissible like flu and COVID, honestly, we tried, but as you can see, it didn't work that well. We did our best, but it didn't work that well. It does work very well when you're looking at these less transmissible things. There's also a very long incubation period for monkeypox, and so when you have an exposure, you can get that vaccine, and the vaccine will prevent it or at least give you a much less severe case.
One of the things that we are learning for AARP, that there are a lot of older adults who have not gotten all of their boosters, and there's still this fear, not just amongst older adults, but even others, of what I'm putting in my body. you know, and what is this? And is it going to have a long-term impact in terms of my brain or my health or whatever? And what would you say to people that have that concern?
Vaccines just don't work that way. So when you take a medication, right, like, you know, your diabetes medication or something like that, you know, you're always taking it. And if we learn somewhere down the road, as we have with a number of medications, that it causes some sort of, you know, long-term impacts, you know, you see the class action lawsuits and things like that from different medications, then, you know, that's because it's continuously in your body over long periods of time. A vaccine simply comes into your body, goes into some cells, and then basically kicks off your immune system to start doing things. It's gone. What was in that vaccine is gone out of your body in no time at all. And all of the rest of what happens afterwards is just that vaccine saying, hey, this looks like COVID. It isn't really COVID, but I'm going to train your body to do all of the things, the T cells, the B cells, the antibodies, and that's your body. That all of that process is simply your own biological processes of your body. So vaccines are not something that tend to have these, you know, what's going to happen 5 years down the road because I took it sort of thing. If something's going to happen, it's going to happen in the near term, like the clotting issues we saw with the Johnson & Johnson vaccine, like the, you know, we've seen some myocarditis with the Pfizer vaccine in young people, but again, the risk benefit on that has basically, you know, the data shows that there's still a significantly higher benefit to getting the vaccine because you can also get myocarditis from getting COVID, and you're far more likely to get COVID and have severe cases of anything related to that than you are from the vaccine in terms of a risk. So it's just a matter of the nature of the way vaccines work.
How do we help fight this misperception? I mean, I even know a medical person who said that their mother got the vaccine and started having heart problems. So you have heart problems and you attribute it to a vaccine. Or how do you fight the misperception that if I get this booster, if I get this, you know, the latest booster, the 2 or 3 boosters since then, since the vaccine, that I'm just putting more things in my body? How do you fight that? How do you tell people that? I mean, it's just information, misinformation.
It is misinformation. You know, you just continue with that message of all of that stuff that's happening in your body is, again, your body's own biological processes. And biological processes cause some of those things as well. There's an inflammatory response. So, you know, you could have gotten the flu or some other thing and that same heart issues may have happened. So there was something predisposed. You know, there's a predisposed, you know,
right. It's not a cause
thing
and effect,
going
right?
on. Yeah, the vaccine, causation and correlation.
Right.
You know, so just because the vaccine, you got the vaccine and then this happened doesn't mean that those two are, that one caused the other.
Right.
It may have just coincidentally have happened at the same time. Right. So, you know, there's a lot of people that want to go out there now and look at what we call VAERS, the Vaccine Adverse Event Reporting System, and say, look at all this, look at all these people that died. Well, the Vaccine Adverse Event Reporting System is a self-report system. I could go in there now and say, this and this and this happened. It has to get verified by the CDC. It doesn't go away. That data in there is not meant for the average public to go in and say, oh, you know, here's what's happening after people get vaccines. It's meant for the scientists and the professionals to look at it and find true patterns that we should be looking out for. And there's nothing in all of that Vaccine Adverse Event Reporting System that has caused us to say, we should stop this.
Right. You know, there's another misperception out there too, that more people are testing at home now, so that COVID's not getting reported as much. But I understand there's some testing in the wastewater in Michigan, that in some other ways that Michigan is continuing to monitor the increase of COVID, as well as what you said earlier about hospitals. They're not people on ventilators, they're not people dying, so the admission of COVID patients is dwindled significantly.
Right.
But talk about the at-home testing in the wastewater and how Michigan is making certain that COVID's not spreading, but not just getting reported.
So we don't need to count every case. Okay? So I'll compare it to flu, only in the sense of, you know, how we monitor flu cases, not in terms of it being similar diseases. We don't test every person who has flu, but we watch our flu seasons. That is done by what we call sentinel reporting. there are provider offices across the country that agree to, when they find somebody that they think has the flu, to test a certain number of them. And we see a pattern. That's all we really need to know with COVID. We don't need to know that, 9,000 people had COVID versus 6,000. The 3,000 that we missed, what's important is that we know, when is that COVID season starting? When has that COVID season peaked? Those are the important things to know, because that tells us, when do we need to vaccinate? It also allows us to watch, the strains, and similar to what they do with the flu, change it to match the strain that's coming for the next year and things like that. And so I actually would prefer to see us go to a similar system with COVID and quit trying so hard to get so much, testing and counting done and reporting and all of that sort of stuff, and just go to more of a, when is flu season is October 1 to April 1, and we just watch, a sentinel system, and we report pediatric deaths. So pediatric deaths are the only thing that's actually mandatory reporting for flu. So with people testing at home, I think that's a great thing, because what it tells me is, one, people are doing that for a reason. You're not going to just test at home just because you're going to test at home and then go on about your business. You're testing at home to use that information to make some decisions.
And the testing's not fun. I don't care how many times you put that swab on your so you're not going to do it just to do it.
I just did it yesterday.
Yeah, right.
And the day before.
Yes, we do it. We do it often, but it's not fun. So you don't do it and stay home just to stay home.
No.
Linda Vale, you have had such an illustrious career. We've got about 10 seconds left. So I just want to say thank you on behalf of our entire state, our nation, our county, for the work that you've done. I know you're going to be retiring early next year, and go on to your what's next. On behalf of AARP and all of Michigan, we say thank you.
Thank you so much.
So today we're going to be talking about budgeting. How do you build a plan for budget and to make certain you stick to your budget? What do we need to know?
That's a great question. We usually recommend starting off by taking a look at all your expenses. And so in doing this is an exercise that can be daunting for a lot of people. But if you take it in week by week chunks, then you could quickly find that you end up spending your money in a lot of the same places over and over again. And so this exercise is really to jot down, to have some sort of narration of where the money is going. You put that in comparison to how much money is coming in, so how much money you're making on a weekly, bi-weekly, monthly basis. And then a good budget would be one where you are making more than you're spending, and then also saving a portion of that on a monthly basis. We recommend a 10 to 15% savings rate for any individual as being a good budget. If somebody were to present that to me and say, this is how much I'm saving, this is how much I'm spending, we would say, okay, well, where's your saving mechanism in there?
And we can all save more.
We can. One of the ways that we look at when we do these exercises with some of our clients is just looking at the small things that we can save. And so it's either making our own lunch at home and bringing it into the office twice a week, or spending less on coffee outside of the office, those kinds of things.
It's amazing what people spend on coffee. Thank you so much. That's absolutely wonderful advice. So let's make certain that we all do what we can to save. Thank you.
You're welcome.
We're going to be talking today. So good to see you all again. We're going to talk a little bit about fall prevention, particularly in the winter months in Michigan. Talk about what people can do to prevent falls.
Oh, it's horrible. We hear this story every day, and it's not a shock. I mean, it's wintertime, right? You're supposed to be thinking about that, but there's not been a lot of snow out there.
Thank goodness.
And so people are saying, well, I'm going to let my guard down. But every day I have patients tell me, I fell yesterday. Oh, I fell 3 times. And lots of times it's in situations they're just not expecting. Snow is melting, kind of makes that little trail from there, and then it freezes later on. They will go back out to the car and boom.
Right.
But the thing I hear about most often is right out their back deck. They go out there, let the dog out, or they went to get the mail or did something, and boom, down they go. And so our concerns has always been fractured hips, closed head injuries, and stuff like that. So the one thing I wanted to kind of put through was, look, don't forget, it's wintertime. I know you're thinking about falling, not falling. But keep that in your brain because it's real important, and we hear it every day. Don't you hear it every day?
So Courtney, we've got like about a minute left. So how do people prevent themselves? What do they do?
So making sure everything's iced, making sure everything's plowed, checking the area before you go somewhere, making sure there's no ice there, making sure the elevations are correct. I had a patient that slipped and fell because she didn't see the curb. So she slipped on that. Making sure that handrails are there, proper lighting, asking for assistance, using canes, walkers, not making sure you just run out really quick without them when you use them regularly in the house.
And then there's the notorious fall at night as you get up to go to the bathroom.
Yes.
Oh, we all love that one.
Yes.
You know.
So it's not just in your own home.
Yeah.
I'm outside. It's in
It
your own
is.
home.
It is. That's
very
right.
important,
So
yes.
just remember, don't fall down.
Yes.
What do people trip over in their own home the most? What do
The
you
dog.
The dog.
Rugs are a big one,
Yeah.
especially in the kitchen.
Yes,
Yes.
yeah. And so at night when they get up, they should.
Sit up, make sure they're not feeling lightheaded,
Right.
nauseous. Just hang out for a minute before they get up and stand.
And
Great.
it does help to have a little light
Yeah.
available.
It sure does. Night lights. too.
Great tips. Hopefully that's news that you can use. Thank you. Thanks for being here. Amy, we are so happy to have you with us today, and we appreciate you being a part of Real Possibilities. You know, so many times people prepare for the surgery. You know, they're worried about the surgery, they're worried about their hospital stay, but they don't prepare for what needs to happen pre-surgery and post-surgery, or pre-hospital stay and post-hospital stay. Talk a little bit about what people need to know before they even have a hospital stay, and also once they're out of the hospital.
Absolutely. Thanks, Paula. So what ends up happening a lot of times is people don't have their documents prepared ahead of time. So it's always a good idea to make sure that you have your power of attorney paperwork, your DNR, your will, checking
DNR being do
savings
not
account.
resuscitate. DNR, do not resuscitate.
Right. Exactly. So you want to make sure that those papers are able to be found quickly and easily. So, most people like to keep kind of private. So, I don't want everybody to know how much is in my checking account but you got to have those things ahead of time. And a lot of times what ends up happening is there's a health event that you wind up in the hospital for, whether that be a heart attack, a stroke, a broken bone. People don't have all of that information ready. So it's always a good idea to have somebody that you trust that knows where to find those things in the event that something happens, just in case. So, we just want to make sure that the transition is smooth for everyone. And so that there's no problems that come up and nobody's going, oh my gosh, I can't find this. And, they need that. So,
And once they're home, what do they need to know?
well, another thing they need to think about is where exactly they plan on getting help afterwards. So whether you're going to go to a skilled nursing facility for rehab, AKA a nursing home. There is another place. I mean, like I said, you can go into an assisted living. After that, what a lot of people don't understand is that Medicare will pay for health coverage. So anything that has to do with your health, they're not going to pay for a long-term assisted living. So that's something that you need to double check on too. So
Thank you, Amy. Appreciate
All right.
that. Excellent
Thanks.
information. There is a lot of information that was shared with you today. Hopefully you will share it with someone else. Thank you for watching AARP Real Possibilities.